And then there's this increasing number of women that go through that pattern of, I'm on birth control, I want to have kids, and wait a minute, I can't have kids, right? And so they're trying IUI, they're trying IVF, and they're on all these, crazy, the IVF cycle. I don't know. It's something my wife and I are going through, and I knew a little bit about it before all of this. Now I know more than I ever cared to know. And I've also learned that at this point, I feel like everybody I talk to has either gone through it or knows somebody going through it, which that's also not normal, right? Or it didn't used to be normal. Now it is. Now it's like, yeah, I'm going to my fertility doctor.
Hey everyone, welcome back to the Reshape Your Health podcast. I'm your host, Dr. Morgan Nolte, and today I'm really excited to welcome back our guest, Dr. Peter Kozlowski. I call him Dr. Koz. He's a board-certified functional medicine doctor and a two-time author of Unfunc Your Gut and Get the Func Out. He's a family medicine doctor who practices, again, functional medicine for a diverse group of patients, from children with autism to adults with dementia. And currently he works with patients online and in person via his Chicago, Illinois office. Today's interview is going to it's kind of a part two. So in part one, a couple weeks ago, we focused a lot on how environmental toxins and lifestyle choices can impact our thyroid and our adrenals. And towards the end of that interview, he brought up sex hormones. And I said, oh, that's a whole nother topic. Will you please come on the show for a part two? And he graciously agreed to share his time and expertise with us again today. So today's topic is all about hormones related to sex hormones. So we're going to talk about how a woman's cycle works, how hormones change after menopause, PCOS, estrogen dominance, and low testosterone. We hope this is kind of like a little mini masterclass on sex hormones, and that you definitely share it with someone who's struggling with one of the issues that we're going to address today. So Dr. Koz, thank you so much for joining us again.
Thanks for having me back. It's an honor.
Yeah, let's just start kind of with the basics. I always like starting at the beginning with the simple things. What are the major sex hormones?
Yeah. So let's start with females and the female sex hormones. And so there's three major ones. I kind of say for women, it's specifically estrogen, progesterone, and then testosterone. And testosterone is more considered a male hormone, but women make it and need it, and don't feel good when they don't make enough of it. And so the female reproductive hormones, as I was saying, are all about the reproductive cycle and pregnancy. And so a woman's hormones are kind of divided into the reproductive years and then the post-reproductive years, which is post-menopause. And there's different types of estrogen, and the main estrogen that is active before menopause is called estradiol. And so these hormones cycle every month, and that's kind of what makes a woman's period. And so we count it in the book that a typical cycle is 28 days. And so day one is considered the first day of bleeding. And the whole point of the cycle is for pregnancy. So everything is designed for a woman to get pregnant. And if she does not, the cycle starts over. And so it's all about preparing the egg and then preparing for implantation. So day one is if pregnancy did not happen, there's something called the endometrium within the uterus, which is basically like a bunch of blood vessels that allows a woman to basically kind of like have a place for the baby to grow, almost like a place with oxygen, et cetera. So this endometrium is made to create this happy place for a fertilized egg to kind of stick into. And so all that vasculature and those blood vessels and all of that kind of sheds, as they call it. And that's what a period is. That's the bleeding, is the endometrium is shedding to start over because the egg was not fertilized. So hormonally, you make lots of estrogen in the first 15 days. That's the main hormone. A woman does not make progesterone during the first 14, 15 days. And starting around day 14, 15 is when progesterone production starts, and it ramps up until the egg is either fertilized. And if it is, then a ton of progesterone is made because that's your first pregnancy hormone. And if it's not, the progesterone goes back down to 0 and you start over. And so that is so important to understand when a woman is trying to figure out whether she has hormonal imbalances. Because when we're looking at hormonal imbalances, we want to look at estradiol, and we want to look at progesterone. So those are numbers that we can do a blood draw and see what your levels are. And there's reference ranges for the first 14 days, the ovulation phase, and then the second half of the cycle, the luteal phase. And so we can do blood tests of estradiol and progesterone. And it's important for a premenopausal woman to measure estradiol and not the other estrogens, because that's the active one. So estradiol and progesterone. And so if you go to your doctor and you're like, hey, I don't know if I have a hormonal imbalance, they'll say, okay, let's go get your estradiol and your progesterone tested. The other numbers that we test are LH and FSH. And so we talked about like TSH with the thyroid in our first pod. And so the pituitary gland is, again, the thermostat, like I describe it. And so the pituitary gland kind of regulates these hormones and this cycle. And so it releases LH and FSH during the different phases. And so typically when a hormone panel is drawn, LH and FSH are drawn as part of that. And the main reason why is because if the estradiol or the progesterone are low or high, typically a doctor wants to know if that issue is coming from the brain, a signaling issue, or is that issue coming from the actual gland, the ovary, right? So if the signal is low, like LH, FSH are low or imbalanced, that means there's something wrong with the pituitary gland and the body's not regulating how the hormones are being produced. Versus, which I don't ever see. I personally have never found a case yet with LH, FSH imbalances as the cause. They do happen, but it's just, I'm making the point it's pretty rare, but that's pretty typical as part of a hormone panel to look at those numbers. And men make those same signals as well, and we'll talk about those when we talk about testosterone. So LH, FSH, estradiol, and progesterone, that would be a good basic hormone panel for a woman. But what I have seen over and over again is a patient will go in and ask the doctor for those labs, and they get an order and they go and do them. And then they're told they're fine. Mm-hmm. And I always ask, my first question always is where were you at in your cycle when you got these drawn? Because this is either very normal or your hormones are a mess. And frequently I hear back, I don't remember. I don't know. The doctor didn't tell me when to go, right? And so the main thing that we're going to talk about is estrogen dominance, because I'd say probably around 3 out of 4 women that come to me before menopause are estrogen dominant. It's very, 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 very common. And so if what I'm looking for, and so what estrogen dominance means is kind of in the name, but it's estrogen dominance means that there's too much estrogen, but it also means there's not enough progesterone. And that's actually what I find is estrogen dominance is not that there's tons of estrogen, it's that there's typically not enough progesterone. And so that's what we need to know where you're at in your cycle to properly tell you, are you hormonally imbalanced or not, right? So I always like to send women to the lab around day 21, 22, 23. And when you look at a reference range for, and the main number that I'm looking at typically is progesterone. And when a woman has estrogen dominance, maybe we should talk about the symptoms first, right?
Mm-hmm.
So classic symptoms of estrogen dominance can be PMS, right? And so that could be heavy periods, that could be irritability, anger, pain, etc. Many women have those issues as teenagers, right? And then most women go to their doctor and they get put on birth control, right? Because birth control basically masks the problem, right? You are taking hormones, and so they're controlling your hormones through pills that you're taking. So the issue kind of goes away. And for most women, the classic story is start birth control at 14, 15, 16. And then whenever a woman is ready to have kids, they stop it. Like, you know, I guess that's happening later and later. So let's say 30, you know, years ago, that would have sounded like a very late number, but that's pretty normal now, I think. That, you know, so we're on birth control from 16 to 30, and now we're ready to have kids, and then we stop it. And for a lot of women, they're like, wait a minute, what's going on? And all these horrible symptoms come back. So PMS, weight gain, cystic breasts, fibroids, endometriosis, abnormal periods, fatigue, hair loss, cold hands and feet, brain fog, depression, anxiety, poor sleep, mood swings, lots of classic symptoms, right? They sound bad, but you know, the more women you talk to, you know, a lot of women are going through that stuff.
Mm-hmm.
And so it is, I mean, I would almost call like the symptoms of estrogen dominance kind of those classic symptoms that a lot of women experience, and then just get on birth control and they kind of forget about it. And it's nice, right? Because, you know, so a lot of those symptoms will go away because you're taking these exogenous hormones. And so you don't really have to worry about it. And for many women, they kind of get, you know, I'd almost say it's getting lucky, because one of the things we'll touch on too is the amount of infertility that's happening. And so for a lot of women, they'll stop the birth control and they can get pregnant, and they'll have, you know, however many kids they want to have. And then so then there's being pregnant, and then there's breastfeeding. So that takes years and years and years. So for a lot of women, it like, you know, we get to 40 then. And now all of a sudden, I'm 40 and I have children, and now I want to focus on my own health. And it's like, wait a minute, all these, you know, PMS type symptoms, are back, and I can't sleep, and my anxiety is horrible. And I, you know, I'm trying yoga and meditation and therapy, and none of these things, you know, they're working a little bit, but I still feel crazy. And my doctor's telling me to take an antidepressant. And so that's a lot of times that women are ending up in my office too, is, you know, in those years where it's like, well, I never really dealt with my hormones. I was on birth control, then I had kids. And now I need to fix it, or, you know, now I'm really struggling. And then there's this increasing number of women that go through that pattern of, I'm on birth control, I want to have kids, and wait a minute, I can't have kids, right? And so they're trying IUI, they're trying IVF, and they're on all these, you know, crazy, the IVF cycle. I don't know. It's something my wife and I are going through, and I knew a little bit about it before all of this. Now I know more than I ever cared to know. And I've also learned that at this point, I feel like everybody I talk to has either gone through it or knows somebody going through it, which that's also not normal, right? Or it didn't used to be normal. Now it is. Now it's like, yeah, I'm going to my fertility doctor, and those doctors didn't even exist, you know, a long time ago, or not even that long ago. And so then that's a whole nother issue, right? Mm-hmm. And so that's kind of I guess a long answer to your question of just trying to start the conversation around hormones. I would say before I finish is just, so when a woman comes to me with a lot of those estrogen dominant symptoms, and for anybody that wants to look at them again, they're all in my book. So it's there to read over and see, how many you can check off. But if we are in the reproductive years, then I will send them for estradiol, progesterone, LH, and FSH testing. And around day 21 of the cycle, usually, like I said, day 21, 22, 23. It's very easy to do. You don't need functional medicine labs. They are your traditional blood work labs that your regular doctor can order. You can go to your local lab or your local hospital, and you get the results typically within a day. So something easy to diagnose and look at. And when you get those results back, typically, and so again, the second half of the cycle and is when the progesterone production should be happening. In estrogen dominance, it's typically not. And so the range, and that phase again is called the luteal phase. The range on most labs is about 2 to 20 for progesterone. They'll say that that's normal. And that's kind of my argument from a functional medicine standpoint, again, is that that's kind of a psychotic range, right? Like, how could 2 be normal and 20 be normal? Those are massive, massive differences. And I don't know what the exact right number is. I've seen some studies and doctors suggest that 15 is the optimal number around day 21. I've read and seen arguments for 10 to 15 as being normal. So I'll typically use that range, 10 to 15, as being normal around day 21, 22, 23. However, this condition is not something that I diagnose based on just labs. And so I don't make my clinical decisions in regards to diagnosing estrogen dominance based on just labs. I really, because we don't know exactly what is normal. And I believe that every woman is different. So for one woman, it might be normal at 8. And for another woman, she needs it to be 18. And so the main factor that I look at is also symptoms, right? And I just had this happen yesterday with a patient where, going over that list of symptoms, she had all of them and they're severe. And I kind of look at the last phase of estrogen dominance where it gets the most severe is all the way to panic attacks. So that is kind of like the nail in the coffin for me for a diagnosis. And I've seen this a number of times now where women are like, I've been having hormonal issues for years. And last month, for the first time ever, I ended up in the ER because I thought I was having a heart attack. And that's kind of, for me, like, okay, we probably have estrogen dominance. I don't want to say for sure, but in my mind, it's usually for sure. Like that's usually the last phase of it where they really need help. So estradiol, progesterone, LH, FSH, the main number we're looking at is progesterone, should be around 10 to 15. And I have all these labs and values in my book. And so someone can reference them using the book. But it is not just the lab, it is the symptoms also. So I can have women with what I would say are mild symptoms. So maybe they check off 2 or 3 things on that list, and their progesterone comes back at like 2 or 3. And then I can have a woman that has all of the symptoms all the way to the panic attacks, and their level comes back at like 7. Wow. And so for me, I would be more inclined to treat the woman with the level of 7, actually, because the symptoms are so severe, than the woman with 2 because the symptoms are milder, right? Yeah. And so when it comes to treatment, right, that's probably the part that most women that are listening to this are like, well, what do I do? Yeah. And I kind of break it down to, there's the basics, which are cleaning up your diet, managing stress, exercising, which are things that everybody should be doing. And most women are trying that, right? But that's where the hormones can play such a big role, that it's like what I mentioned earlier is like, hey, I am in therapy. I am doing meditation. I am doing a gratitude list. I've started doing HRV, but I still feel crazy. And I can't, this stuff isn't working that well. And that's where growing up as a like young, immature male, you kind of just think women can be a little crazy sometimes.
No, really? My husband would never say that. Just
Yeah.
kidding.
And so learning about hormones and working with so many women over the years, I see it right away. I'm like, this is not your fault. Your hormones are just out of control. Like, they're not balanced. And so no wonder you feel a little nuts. And so that has just been something I've learned over the years. Is so when I talk about the basics, like, it sounds easy, sure, do the elimination diet, sure, go to therapy, do these things. But if your hormones aren't cooperating, and so it's kind of this hamster wheel, right, that women are stuck on. Mm-hmm. And so then the second thing is supplements. And there's different supplements that I've used. And for me, supplements can help, but it kind of almost depends on the severity of how bad the symptoms are. So if we're talking about a woman that has 5 or more of those symptoms, let's say, I honestly probably will advise that supplements probably aren't going to help. And in my opinion, the best supplement that I've seen is chasteberry. Chasteberry, and it's known as Vitex also, is been shown to decrease estrogen and increase progesterone. So that's pretty much exactly what we want, right? And then there's supplements like adaptogens and other herbs that can help estrogen detox. There's multivitamins, there's B6, there's magnesium to kind of calm down, ashwagandha, things like that. And I have some of those lists, but it again, to me, kind of comes down to the woman, the age, the symptoms. And so I haven't found a supplement regimen that like has fixed the problem, is my honest truth. And so what I have found for many women to be kind of the magic cure is progesterone replacement. Okay. And so I have used bioidentical progesterone. So that term, many people have heard that term, bioidentical, and it's almost one of these buzzword trendy terms, and a lot of people don't even know what it means, but it sounds cool. And so what it does mean is, when a woman, like if you go to your Walgreens or CVS or whatever pharmacy and your traditional doctor puts you on birth control, those hormones are synthetic. They are made in a laboratory. There was one that was like made from horse urine. And so they can be, the problem not so much as the hormone. The problem is your body detoxing that hormone, because you have to break down estrogen. You have to break down progesterone. And so the more of the problem with those kind of medications is the detox, is that as you're breaking them down, they can be really toxic. And that's where I think a lot of the issues come from. So biologically identical hormones mean that they're biologically identical to what your body is normally making. And so there's not that detox. The detox is more normal in regards to not creating a toxicity, and that's what makes them safer. So what I have found to be the magic kind of solution is bioidentical progesterone replacement. And that is, and we do it to mimic what your body should be doing. So what that means is, if I prescribe it, I only prescribe it on days 14 through 28 of your cycle. And it is taken 1 hour before bed. And the dosing can be anywhere from 50 to 200 milligrams, and your doctor should be helping you make that decision. And it I've seen it completely change women's lives, like unbelievable. Women that were in, ER many times for panic attacks and years and years and years have never been back. And all of a sudden, all the mental health stuff is working, right? Therapy is easier. Relationships are easier. Meditation is easier. Yoga is better. All these things, all of it, then all of a sudden you get off that hamster wheel. And instead of everything kind of making each other worse, everything is getting better, right? Each thing is starting to work better. A question that I get a lot is a lot of women, when they think of hormone replacement, they think cancer, right? And there was a lot of cancer from hormone replacement, and it was those like synthetic ones from horse urine that were a big problem. And again, that comes down to the detox. So to me, progesterone replacement is actually, I would argue, it's more preventive against cancer, because many female cancers, whether it's breast or uterine or ovarian, are estrogen driven, right? So if you spend your 20s, 30s, and 40s in an estrogen dominant state, I would argue that that would put you at a greater risk for cancer, right? Because most of those types of cancers are estrogen driven. Whereas if we get you on a biologically identical form and we balance your hormones, they're going to be cancer preventive or protective, ideally. And so, I mean, obviously, when it comes to something like cancer, or anything I talk about, there's so many other variables. There's stress and diet and toxins and all these things. So I'm not saying that progesterone will definitely prevent cancer, but at least from a common sense standpoint, that most female cancers of the reproductive organs are estrogen driven, that progesterone is going to be protective of that, right? And so that's what I've found to be kind of the magic solution. And probably the biggest question that a lot of women are now wondering, because I've heard this almost instantly so many times, is why didn't my OBGYN bring this up to me, right? Why didn't my family practice doctor, if this is such an easy answer, why aren't they talking about it? And so I still don't have the answer to that. And I think it gets back to just the pharmaceutical industry control of what we do as traditional doctors, because bioidentical progesterone replacement comes from a compounding pharmacy. It comes from a natural source. Frequently, they're made from yams. And so there's no money in it for the pharmaceutical industry. So we're not really taught it as traditional doctors, because as I mentioned, my wife and I have been through the IVF journey, and my wife has been to many OBs over the years, and I've been to some of those visits over the last few years. And so I always ask at the end, because I'm trying to find out, why aren't they addressing this? And every OB I've asked believes in estrogen dominance, but not one of them has really been able to answer me why they're not treating it. Or they'll say like, yeah, we just use birth control.
Mm-hmm.
So long
that's
answer.
so good. I have a few follow-up questions before.
Okay.
I'd like to, I'll give you a drink. Here's your rest break. That was such a good explanation, Dr. Koz. Thank you. So I was taking some notes as we were talking. What if someone has an irregular cycle? You say, I think I understand it, but I just want to be sure that a lot of people who may be estrogen dominant, they might have very irregular cycles. And you mentioned to test around day 21, 22, 23. So just to clarify, the first day of your period is day 1.
Mm-hmm.
So then you would count out 21
Yes.
days after that. So even if you have an irregular cycle, you would suggest just wait till you have your period again, and then kind of be ready to get tested. Okay.
Yep.
The other thing I think is often under advocated for is the risk of blood clots with birth control. So we kind of mentioned that if you're taking the synthetic birth control, often for decades, you may be increasing your risk for certain reproductive cancers. You're increasing your risk for blood clots like pulmonary embolisms. I know a girl who was in my class in high school. We played soccer together, in her 20s, almost had a fatal pulmonary embolism from birth control.
Wow.
And so I
Wow.
saw a Facebook post of hers once just really advocating for women to be aware of that risk. Are there any
Wow.
other risks? And by the way, this is not the girl's fault. My high school volleyball coach, when I was super moody, she was like, I think that you might want to go on birth control to kind of calm yourself down. You know, what high school girl isn't super moody? And so I did, and I didn't know any better. And then in college, I was really, I felt really numb. Like I was in this relationship that wasn't serving me. And I'm like, why am I not more motivated to get out of this? Why do I feel numb to this? And then I felt just a little bit bloated and heavy. And I'm like, I think it's the birth control. And I got off of it, and I felt like I lost 10 pounds really easily. And then I felt a lot more mental clarity and focus. And so for me, those were my personal symptoms. But do you notice any other symptoms or risk factors of the synthetic birth control?
I mean, if we opened up the pharmacopoeia, the list is probably endless in regards to the side effects. For me, I haven't prescribed birth control in over 10 years. So I don't, I'm not up to date with all the side effects that they list. When I was in a traditional family medicine practice in residency, then yes, I prescribed birth control, and I could probably name off all the side effects. But I would imagine it's anything, headaches or joint pain, or you can have irregular periods or more regular periods, or it just gut or urinary. The symptoms I think are kind of potentially endless.
Kind of a Pandora's box. It could be the birth control. Okay. The other thing that I just wanted to mention was anyone who's listening to this and they feel like they're struggling with estrogen dominance, they probably have anxiety. As you said, they might have some degree of depression. Both of those can make implementing the lifestyle changes so much harder, like such an uphill battle. So I just wanted to acknowledge anyone who's trying to make those lifestyle changes. Don't give up. You are facing a little bit of an uphill battle if you're trying to improve your physical health with mental health kind of issues or unresolved problems. I always encourage people to really focus, if not in tandem, first on their mental health and then on their physical health, because I feel like they do go hand in hand. And as your physical health improves, your mental health improves. But if they're really stuck in that crippling anxiety, like I think really getting to supplementing or progesterone faster to help get them out of that so that they can be a little bit more effective in implementing lifestyle changes is really wise. And then a couple other questions on the supplemental. Let's kind of start at the basics. So why would someone have low progesterone / estrogen dominance? Like what are the environmental or physiological causes of that? If someone wants to try to prevent that in the first place or reverse it, almost like reverse engineering the cause for their treatment. So I'll ask you that question first, and then I just have one more follow-up question.
I always say the risk is just being alive in 2023 now. And I personally believe, and I write it out in the book, is it's our toxic environment. And I think maybe probably even one of the most interesting things, and I go through the full, I'm sure the list can be longer, but I have a list in the book of xenoestrogens. So the first time we talked about, and what I talk about the most in the book, is the damage that toxins do to all our different cells, right? And so the damage can be done to the ovaries. So then the ovaries, the production kind of gets screwed up. And so, but the other thing that women are being exposed to are called xenoestrogens. So these are toxins that are not only damaging your cells, but they can bind to estrogen receptors. And so your body is responding as if it's making extra estrogen, right? And your estrogen levels won't even show it, but your estrogen receptors are activated and functioning as if they've been turned on by estrogen because of xenoestrogens. Birth control is considered a xenoestrogen. Chlorine, sunscreens. So we are talking about like household products, right? building materials, things like that. These are things that women are using and touching all day, every day. And so we're absorbing these toxins through our gut, through our skin, through our lungs, and then they're going around and binding and activating the functions of estrogen. And so part of the problem with diagnosing estrogen dominance or hormonal imbalances is difficult on lab work is because it also comes down to the balance of estrogen and progesterone. And there are doctors that make arguments for what is the proper balance, but I think that also gets screwed up because of xenoestrogens, because those aren't reflected on blood tests, right?
Yeah.
And so that's where it's a very, very difficult world to work in, because it's not easy. It's not clear cut. It's not like, okay, your blood pressure is 160/90, so you have high blood pressure. It really involves listening to the person and working together with your practitioner to make it a proper diagnosis, and then figure out what is the best treatment plan. Because also an important point I wanted to make is I don't put all women on progesterone, and specifically, if a woman is past their baby making years, that they're like, listen, I'm done having kids, and I will not really hesitate in that case to use progesterone. If I'm working with a 20-year-old or a 22-year-old or a 25 or 27, which is common, and they're like, I have not started any baby planning yet, I typically try to avoid progesterone replacement in younger women. And because that gets into the whole, when we give your body a hormone, we're telling your body you don't need to make it, right?
Oh,
and so I wouldn't want to turn off a woman's hormone production over the long term by putting them on a hormone. But that again, it really is individualized person to person, but if you're 22 and your progesterone is 1 and it should be 15, are we really going to be screwing anything up? You're already not making it. Right?
Yeah, that's true. Yeah.
I will always try to detox, right? So I will test for heavy metals and glyphosate and mold and all the non-metal toxins. And I would rather try to detox, get the gut right, show that the diet has been balanced, work on mental health. And so we have time in that situation to try to get the body to work regularly again. But if we're talking about a 22-year-old that's in and out of the ER every month, I think we're doing more good than harm, and you need progesterone, as I mentioned in the beginning, to get pregnant too. So actually being on progesterone could make you more fertile, because you need progesterone. So if you're not making it, you're also going to have a harder time getting pregnant. And then a lot of women that have been through like miscarriages, they've been told, hey, we tested and your progesterone's low, so if you get pregnant again, we're going to put you on progesterone right away, right? And they do that during IVF, and they do that during regular pregnancies too. So there's a lot that goes into this, and so it's not the same for every woman. But to keep it simple, I would try, if it's pre-pregnancy years, I try to avoid hormones. If it's post-pregnancy and the symptoms are inhibiting quality of life, then I'm more aggressive to recommend hormones.
Now, with someone who's post-baby making years, would they have to be on the progesterone indefinitely, or like until they go through menopause? Is that
everybody's different?
Everyone's different. Okay.
Yeah. So we're going to detox, and some women I've seen get off of it. Okay. Some women have gotten off of it, and a month later they're calling us and saying, ASAP, please get me back on it.
This is not good. Yeah.
Yes. So I always encourage, like, if we got on it because of symptoms, but that was before we started the functional medicine process, and now it's been a year or two and we've gotten the body cleaned up, then let's try and see, sure. And worst case scenario, we could always start again.
Yeah. Okay. I think that that was a really great discussion. And again, Dr. Koz's book is really full of details and tables and like lists of those xenotoxins and other toxins. And so I highly recommend that as a reference point for people if they want to dive deeper. Before we transition, we have a little, 20 minutes or so left. I wanted to touch a little bit on PCOS and low testosterone. So will you kind of, if we can balance our time a little bit, I know we've covered a lot of women's health issues so far, but I didn't want to neglect men with low testosterone in that discussion too. So really quick on PCOS, what are some major causes of that? So that's polycystic ovarian syndrome for people that aren't familiar. Is that related to estrogen dominance at all?
Yeah.
Okay.
Yeah, a major reason that PCOS is happening is too much estrogen and not enough progesterone. Okay. And then I would say the other major thing is diet and sugar. Yeah. And because your fat cells can make hormones, right? So another way that you can end up estrogen dominance is just by having too many inflammatory fat cells, which I would argue all fat cells are inflammatory, that are also then making estrogen. So imagine this world that we're living in where the obesity rates, I mean, who knows, they're over 50%, 70%, they're through the roof. So you've got, all these extra fat cells that are making estrogen. Then you're putting on sunscreen and taking birth control and rubbing, and all the different bath and beauty products, and all of that is activating more estrogen, right? So a lot of women are living in this hugely high estrogen state. So yeah, one of the things that can happen is the polycystic ovaries. The sugar thing is interesting because if a woman's ever been diagnosed with PCOS, the number one drug that is used is a diabetes drug. Yeah. Yeah. It is a drug called metformin that makes your insulin receptors more sensitive. So you basically can store sugar better, right? And that is the best medication and treatment they've found for PCOS, right? And so from an alternative standpoint, it would be cleaning up the diet, right? Unfunking your gut, like in my first book. And that's looking at food sensitivities. It's cutting down the sugar, cutting down the stress, exercising more, all of these things to lower sugar, lower cortisol, that will then allow the hormones to kind of heal, right? So it is, again, just point proven that it's a very complicated process and there's a lot of factors. So I'm not saying it's just toxins, it is diet, it is stress, and it is all of these different things that are playing a role. Yeah.
I think it's really important to highlight, like inside of Zivli, we have kind of our 4 pillars. We have nutrition, including, we didn't even talk about fasting today, but that's a whole nother topic for gut health. What you eat, when you eat, stress, sleep, movement, it's all on a foundation of mindset. And so I like just bringing that up because people kind of get hyper-focused on, I got to fix my diet, but then they're completely neglecting their chronic stress or sleep deprivation, and so I think it's really important to kind of put first things first. And I really think it's way more effective to focus on the simple things. And I say simple, that doesn't mean easy, but like hydration. Are you drinking pure, are you drinking enough water? Are you getting 7 to 8 hours of sleep a night? Let's start with that before we get all down the fasting tract and really improving your diet a lot. It's like, let's kind of tackle the lower hanging fruit. Again, it's not always easy, but that's going to make other things easier. So I love having this more holistic conversation on it's not just this, it's not just that. It's like everything plays together.
Just a quick comment on what you just said is that, because the other half of my book is about toxins and detox, and and my biggest pet peeve in this alternative medicine world is all the people selling these detox products and all the money that's spent on these products for detox. The best ways to detox are detox is just turning toxins that are fat soluble, making them water soluble, so you can pee, poop, and sweat them out. So the best way to stimulate detox is to drink enough water, so you pee.
Yeah.
It is to unfunc your gut so you poop every day. If you're not moving your bowels every day, you are not ready to detox. It is exercise and sweating, because that's another way that toxins are coming out. It is sleeping because and managing stress, because cortisol and stress will stop you from detoxing. And then all of those, if you're not detoxing, well, then your hormones are going to get worse and worse, right? So again, it all builds together, but those are, the basics that everybody jumps over and jumps straight into a supplement or something. But, there's very simple steps that can be taken that will help heal hormones or help detox.
Yes. Thank you for bringing that up. I think the last thing that before we move on to the low testosterone is just to cover how estrogen production changes after menopause. We've talked a lot about premenopausal women. And I've said this multiple times, but I just want them to hear it from someone else on why stress management and proper sleep is so important as women go through perimenopause and then are postmenopausal as it relates to weight loss and fat loss.
So during the reproductive years, the majority of hormones are coming from the ovaries. That's the majority of estrogen, progesterone production. There's a little bit coming from the adrenal glands. And then we talked about the fat cells. Well, after menopause, the ovaries are no longer making the estrogen and progesterone, and it is, or maybe just a tiny amount, but the majority of production is coming from the adrenal glands and the fat cells, right? Mm-hmm. And so that, and a very interesting thing is I would say the symptom that I've seen that bothers women the most after menopause are hot flashes, right? And so most women just assume it's like, well, I'm not making enough hormones. And there's studies that actually show that cortisol and high cortisol is a bigger trigger of hot flashes than the lack of hormones, right? Because not every woman goes through hot flashes, right? And so cortisol is actually a bigger player in something like hot flashes, which is something probably most people don't recognize.
Yeah.
So yeah, I mean, we're aligned that, whether we talk about gut health, hormones, toxins, reproductive years, post-reproductive years, at the end of the day, the most important part of all of it is your mental, emotional, and spiritual health.
Mm-hmm. It is. Yeah.
And not just to have better relationships, but to better make hormones and to better detox and to have better thyroid function and to have a healthy microbiome, and for all of those reasons as well.
Do you talk about that in your book? I was just wondering, the mental, emotional, spiritual stuff.
Unfunc your gut. That's the whole point of the book, is that the key to your gut health is mental, emotional, spiritual health. And then
I'm excited to read that. Yeah.
Chapter 2 of the Get the Funk Out is the adrenal gland chapter. And so that is all about mental, emotional, spiritual health. And I think I end the entire book with just that, the most important part of all of this. So that's my biggest pillar that I stand on, I guess, is explaining that importance of that piece of health.
Yeah. I've only used your book as a reference point. So I've kind of like, if I had a question about something, I'd go to it, I'd look at the tables and that kind of stuff. And in preparation for the interviews, and right now, Dr. Beth has it. She's our Zibly health coach. And I'm really excited. I feel like I'm kind of ready to take in some new material. And the way that I describe it is, if you don't have a strong mindset, it's like you're building your house on sand. Mm-hmm. And you can work on fasting, you can work on nutrition, you can work on stress and sleep and exercise, but you won't be able to be consistent. And it just kind of all topples over if it's not on a strong foundation. So I think that's so important. I know that you've been through that. You kind of mentioned that in your first interview.
Yeah.
Yes, big head nod. Let's kind of finish up today in the last, 10 or 15 minutes, just talking about testosterone and sex hormones for men. So I'm just going to hand the mic back to you and see you in 15 minutes. No, just kidding. But pretty much.
So testosterone is kind of known as the male hormone. And so just as much estrogen dominance as I'm seeing is the reverse of that for men, is how much low testosterone we're seeing. And just like for women, men kind of have their reproductive years, which can last longer and longer now. I mean, I've heard about men in their 60s and still having kids. So it's a longer cycle. But our testosterone production is peaked in our like late 20s for most men, and then it kind of should decline slowly. I was diagnosed with low testosterone at the age of 32, and I think I probably had it for a lot of years before that. I've diagnosed men in their 20s. I've also tested men in their 60s and 70s that still had perfect testosterone, and I've been very jealous, but so it doesn't happen to everybody. So men need testosterone for lots of things, for brain health, for bone health, to build muscle. It helps turn muscle into, fat into muscle. So there's lots of these awesome qualities that testosterone has. And for many of us, we don't make enough of it. And for me, I always just thought, the main symptom that I had during my 20s, I'd say, is that I've always been very into exercise, sports, weights, and just a very active lifestyle. And a lot of my friends were that way. And I always felt like I worked out just as much as they did. We all had crappy diets back then. So we would like go to the gym and then go get McDonald's right after. But they would be more cut up, as I would say, right? And for me, I was never obese or fat, but I just carried more weight than I thought I should be for how much I worked out. And then I cleaned up my diet, and I still I was like, why am I not really getting to the place where for the amount of work I'm putting in, like, what is going on? And so then I was working with a doc, and I was telling her about my life a little bit. And she's like, I think you have low T. And I mean, I think in my mind, I cussed her out. I was just like, I'm 32, get out of here. But I was like, fine, I'll humor you and I'll test. And so my testosterone came back in the tank. And so the testosterone on a lab for a man ranges somewhere between 200 to 1100. Right, which is another just completely nuts range. And so I was around 200. So I think maybe they report normal as being 400, let's say, maybe. Depends on the lab. But I was like 50 points or 100 points below normal. And I mean, I was just stunned, but at the same time, all of a sudden, like, my whole life made sense. And so I went on testosterone replacement. I saw these numbers. And so she's like, I think you should go on a testosterone cream. And I was like, let's do it. And I was on it for 3 years. And I would say it was the best years of my life. Like, I felt amazing. I was, and a lot of people, when they think testosterone replacement, they think like Barry Bonds or like these baseball players that were on all these, more like the steroid thing. Yeah. So we're not, when we do testosterone replacement as in my practice, it's just to get the levels normal, which a lot of people argue what is your optimal testosterone is around 800. So that's usually the goal that I'm trying to get at with replacement, is around 800. And so that's what I did. And some of that little excess fat turned into muscle. Like I was pretty close to a 6-pack at one point. Like I didn't change anything. Like I kept the same diet. I worked out the same amount. It's just my body completely changed. My mood was better. My sex drive was way better. I just felt better about myself. And for somebody that's dealt with like addiction issues and depression, like, it felt great. And I had no side effects that I was aware of. Like, it was just, everything was wonderful. And then I met my wife, and we wanted to have kids. And for the first time, I kind of thought, I'm like, in my mind, I was like, well, the testosterone, I should be super fertile. Like, we should get pregnant right away, right? Because you need testosterone to be fertile. And I did a sperm analysis, and zero sperm. And one of the, I think still probably the worst day of my life. I've had some pretty bad days, but that I still think that was the worst. And I was like, holy crap, what did I do to myself? Right. And why would that happen, right? And so this is something, and I've heard other people young age like me that were told to go on testosterone and didn't get explained the side effects. So this has kind of been my mission in life for men to not go through what I went through. So why would that happen, right? Well, LH and FSH, those signals from the brain, are the same signals that we talked about with a woman. They're the same signals that tell a man's testes to make testosterone and to make sperm. LH tells you to make testosterone, FSH tells you to make sperm. When you are on testosterone, those signals turn off, right? Because the brain is detecting, hey, your testosterone's at 800, we're good. That's fine for LH because you don't need testosterone production. That completely shuts off your sperm production when FSH is deactivated, right? And for a lot of men, I did what, well, first of all, I did what I tell everybody not to do. I got online and started reading. You know, a lot of men don't ever make sperm again. And so that's, of course, I assume that that's what would happen to me. And so I became kind of an unofficial expert, at least just for myself, in making sperm and making testosterone in a different way. And so I found all types of supplements, and I've got a list of probably 15 different supplements that I used in the book. And I also used a medication called clomiphene. Clomiphene is a medication that a lot of women are familiar with that have been through infertility, because it basically causes you to make more LH and FSH, which can stimulate ovulation in a woman. For a man with low testosterone, a lot of men use it, clomiphene, just as their first choice to increase their testosterone levels, because it basically creates this negative feedback that causes your LH and FSH levels to go really high, so you make more testosterone. I did it to make more FSH in order to hopefully turn on sperm production again. So 6 months of supplements, you know, and I already, you know, diet and things like that were pretty cleaned up. Stress was higher because of, you know, the fear that I basically made myself infertile. At 6 months, 0 still. And then at 12 months, totally normal again. So it happened for me somewhere between 6 and 12 months. I don't know when, because I wasn't checking every month. And so now I'm back to normal. When my wife and I are done having kids, the first thing I will do is go back on testosterone, because it was amazing for me in regards to how I felt. I have had some men, it's very rare that will start it and they don't really notice a difference. I can't really explain that. Some men have side effects. One that I saw was breast growth, which is obviously a very negative one. So again, this is not going to be the magic solution for everybody. Testosterone replacement, there are so many different ways to do it. Traditional doctors love to use the injections. I hate that because for most men, you get an injection every 2 weeks. Well, the day of that injection, your testosterone spikes to like 2,000. And then over the course of the next 2 weeks, it goes back down to 200. And then it skyrockets to 2,000 and then bottoms out. And that's just traumatic for the body, right? Like that I think can put you at cancer risk and other things, because that's just not what the body is normally doing. And so I used a cream, which I'm convinced is the best form, because it creates just a steady state. I used it in the morning and at night. And so my testosterone levels were just always even. And so supplement, I mean, there's the lifestyle stuff, you know, that was the same as we talked about for women. There's supplements, which are in the book if someone wants to take a look at them. Clomiphene as a medication, an oral medication, and then testosterone replacement. And so, like I said, there's many different routes. There's doctors that are doing these pellets now, where they basically like stick something under your skin and you only have to put them in every 3 or 6 months or something. That can be expensive, and it's also a surgical procedure. traditional doctors use androgel, which is a gel. I think that's pretty close to the cream that we use. I use. So I don't know what is the best way. I mean, there's testosterone experts that are doing, everybody has their own niche. To me, the cream made sense just because of keeping a steady state. That's what I used, and it worked wonderful for me. But for any man that is in the reproductive years, don't do that. Or what I have for some men that are like, I really want to be on testosterone, but I don't want to lose that ability. You can do testosterone and clomiphene. Right. So you put on the testosterone to get your levels up, but then you add clomiphene to keep the FSH signal active.
Okay.
So again, get into a very complicated process. And my advice always in both books is to just find a practitioner that, you're comfortable with and that has some experience with whatever condition you're working with. I always recommend ifm.org and searching for certified practitioners, but also not every practitioner that is certified with IFM or whatever is going to be comfortable with toxins, and some might be comfortable with female hormones and some male, or some both. Some might just do gut health, some might do nutrition. So just make sure that the clinic that you're reaching out to has experience with whatever issue you're working with, because not everybody will have comfort with all of these things.
Yeah. And I know you're based out of Chicago. Do you work with people around the country virtually if they wanted to reach out for a consult? Yeah.
Our website is the best way to get a hold of us. Just okay. Email us or call us.
Yep. And we will link the ifm.org and your website up in the show notes for this episode, both in the blog post and then also on YouTube and the podcast. And Dr. Koz, I really appreciate your time today. I know that you're an expert in a lot of things, functional medicine. Oh, hit my mic. But I think that, I've talked to a lot of different experts on here, and I can always kind of tell who really knows their stuff on a really in-depth level, but then also who's like lived it. And so I really appreciate you bringing in that personal experience and being vulnerable with your and your wife's fertility issues too. And we wish you the best there.
Thank you.
And I hope, I wish you I wish you the best with business. I wish you the best with life. I really enjoyed both of our interviews and just can't thank you enough for your time.
Thank you so much. And same to you. Thank you.
Thank you. Bye.